Hi, Dr. Alan Nasipany back at the University of Idaho.
Hello, Jim May, University of Idaho.
And today we want to talk a little bit about choosing our variables and how we would do it, and maybe a little bit of focus on independent variables and dependent variables, but hopefully in a way that's unique.
Yeah. So let's start off with a starting point, or the assumption that we're going to be studying a specific technique on a patient population that we have a desire to learn more about. We see it as meaningful to our clinical practice, and we want to study that. Okay. In big picture, from a technique perspective, we would generally recommend that we isolate cause and effect of sorts as well as we can in clinical practice, right? So, for example, if we were going to use the Mulligan concept to treat a specific patient classification, we would also be aware of that if we added strengthening, we added stretching, and we added other rehab techniques, those kind of things. That would muddy the water of sorts, and when we lose our awareness of really what the specific technique was, what the cause was to that population.
Yeah, you just have too many variables in there, and all of them could have been a factor, but it's probably unlikely that they were all factors. And a lot of times the more we do, when we start getting these variables all at the same time, a lot of times some of the effects will start to cancel each other. And
Yeah.
if you don't know that either, then you don't know that your technique didn't work, or you put too many things together that kind of counteracted each other.
Which is a common pattern in clinical practice, right?
Yeah, the shotgun approach.
Yeah, you use many modalities to provide care, and then we don't always know which was most helpful, and sometimes it's important to extrapolate that.
Yeah, so for a dependent variable, just make sure you know what you want to do, and as best as possible, use one thing at a time. And one way that we get around that here is that, let's say we're using an isolated treatment technique, but we're probably thinking that there's probably other things that we're going to need at some point in the rehab process, or maybe we do. Then we would start by focusing our study on the immediate effects. So the day 1 post, day 2 pre, right? In that little window, now you're only looking at a 24-hour window where you've kind of kept things clean. And then at that point, maybe you make a decision whether you continue going on that, or whether you just stop it there for that session, or for that study. And that's a way that we can do it. We can keep it clean.
Yeah, and it's helpful that we're using techniques that we expect an immediate change.
Yeah, that's a good point. Like when I went to school a while ago, what I learned afterwards was basically we weren't expecting anything we did to work in a reasonable time frame. We were looking at what we call the natural course of healing, which is if you don't do anything, how fast would you heal? And that's all those factors that are just nature.
And hopefully we beat it.
Yeah, and hopefully we beat it, but a lot of times it's, we didn't stay out of the way enough, and we prolonged it. Or we did things like stretching that's going to work over the course of 2 weeks for a neuromuscular change, or 12 weeks for hypertrophy. Like, let's say it actually is a strength issue. It's going to take you some time. But what we've found in our practice is that's almost never the case. That almost every time somebody has a strength issue, it's an apparent strength issue. It tests like a strength issue, but we know it's not an actual muscle issue in the way that we would commonly, or tendon issue, the way we commonly think of it, because we can change that in one visit and it stays better. Like if that needed hypertrophy, that wouldn't be the case. Or if that needed neuromuscular control, that just wouldn't be the case. And so we understand that. Same thing for pain and all these other things that we study. So based on that, we have an understanding that, hey, we can do a short window and we still should see effects. Like, I know this treatment works in one visit, well, then maybe it's okay to keep our range one visit. The piece, I guess, that's added to that is a lot of our treatments don't only focus on, or they focus on more than one area at the same time. So for example, if we do, let's say, the Mulligan concept ankle, well, not only does that help with pain, but it also helps restore range of motion. And because we're somehow probably changing the joint receptors, it's changing their ability to produce strength. It's changing their agility. Like, all of those things are changing with that one technique, which allows us to study one technique at a time. Also, there's been some studies where they've started to look at edema, and we've shown that when we do that, the edema changes, right? So we're kind of one technique, one set of that could potentially change all these different markers, and it's useful to know how well it does that.
Yeah. So
or how good I am at doing that, one of the two.
So when we have those pre-measures before care, we establish a baseline. And then after care, we use outcome measures that are both clinically oriented and patient oriented.
And our clinical oriented ones are things that we normally do, like range of motion and strength and maybe agility or endurance or joint laxity, all the things that the clinician is doing, and you kind of need the clinician training to do.
We want to assess those items that we expect to change, like what we've talked about. If it is pain, if it is function or range of motion, or more patient-oriented quality of life changes. So we can integrate those in to best assess the changes.
And then we also want to include some patient-oriented outcome measures, or measures that we call more subjective, but really they're probably more important. Like, if your patient doesn't think that they're changing and you do, then that's not good enough. That somehow that has to get translated to how the patient feels. Maybe it's just having a conversation, or maybe you're missing something. And so the combination of these more objective measurements and tests, plus the perception of the patient, because the perception of the patient is probably 90% of your treatment or rehabilitation process. Now, if they come in and they have 10 degrees of motion, they're supposed to have 90, then obviously that changes. Like, it doesn't matter if they feel good about that. If they still can't move their arm or their leg, there's still a problem. But in general,
so
we care about patient-oriented measures.
So you want to include a disablement model?
It could be a disablement measure. It could be some sort of, like the DPA scale or the short form now. That's pretty good. We've got that in a place, and Dr. Vela had that to start with, and we've modified that here, and it's a pretty good snapshot that looks at the same measures that you're potentially collecting from a disease-oriented or a clinical, clinician-based outcomes. But you're now asking the person, well, how do I feel about range of motion? So now we have the data about what the range of motion is doing in the time that we're measuring it. But then we also say, well, how do I feel about my ability to, move through a range of motion, or strength, or function, or any of those things? And what we've seen is both of those are extremely useful. If they have all of the right function and motion and strength and all of that, and they don't feel good about it, that's a disaster waiting to happen. And if they feel good about it but they can't do it, they're probably not going to be very athletic. Also, combined with a disablement model, or some sort of model that includes quality of life, especially health-related quality of life, is we start to get those measures about stress in my life and how I'm able to cope, and am I happy, all those things. And again, if somebody is missing one of those areas, let's say that their unhappiness in life is 80% of their issues, and their ankle is only 2% of their issues, and you get their ankle 100% better, that's only 2% better. Whereas if you help them do whatever in their life, a lot of that's just by changing perception, and you get that half better, now you've increased that 40%, which is a huge win, and way more important than their ankle would ever be.
Yeah, a wonderful wellness model.
Yeah, and then that way, now you can help the ankle and everybody's happier, right? And so some of those models that know about or that at least target those things that are important to people. Are they healthy? Are they happy? What's their stress level? How are they sleeping? All of these things, in addition to the very microscopic things that we're talking about with their injury. Because you don't have an ankle sprain walk in the door. You have a person that has an ankle sprain. And that's an important distinction to make. And so generally, if we get some combination of patient-oriented and disease-oriented models mixed together, we're going to get a pretty good snapshot that probably is going to be way more accurate than if we just look at one of those in isolation. So generally, a couple of measures of each, maybe not let's say we use the DPA scale, maybe not another health-related quality of life measure, but maybe we use a specific area of that we think that these patients that come in with this type of issue typically have. And we're going to scan that to deep dive into that area of how the patient feels. Same thing with a disease-oriented measure. You can do the same idea, is that you can get some that are the normal and then some that are specific. For example, if we're doing ankle, and we can use the Mulligan concept, the dorsiflexion test. The weight-bearing dorsiflexion.
Weight-bearing dorsiflexion.
And that can tell us a level of function that's beyond non-weight-bearing open chain range of motion.
And it's efficient.
And it probably translates better to function. Mm-hmm. So all of those ideas hopefully are helpful, and there's way more.
Yeah, and it's a balanced approach, right? So if we look at the disablement, we want to have a pre to a post, and that's usually going to be, to 3 to 4 days to 7 days that we would assess. So we want to make sure that we have what we're going to capture immediate changes, and also that 3 to 4 or 7 day windows that we can function on.
Yeah, we'll have some more on these afterwards, I suspect, because we get into some things like using a scale that's only been validated once a week, and we try to use it every day.
Yeah.
Which may be fine, because maybe they never tried that. Or maybe we need to know over the course of a week that there's too much variability or something. But we can come back and talk about those another time. This is kind of like the maybe 500-foot view of how we look at a lot of the variables in a clinical research process.
So know what you expect to change, and work to best assess those changes.
Yeah, and then when you start to utilize those, see if you can pick the best tool for, because you can hammer a nail with a wrench, but maybe it's not your ideal, right? And so if we start to pick measures that are valid, they're reliable, they've been validated in our patient population, like all of that is just really good. And then the more we do those kind of things, which is really the easy area, especially if it's been done before, that's really the easy area. Where the reward is going to be is that you're going to be able to say a lot more about what you're studying. And if you don't do that, then there's always going to be like, well, this wasn't really validated, but we suspect it worked, but we didn't find anything. And then it's like, okay, well, do we know, what the tolerances are and all of that. So it's best if you can use things that have been validated. Occasionally you'll use a tool that's been validated that you haven't validated on yourself. Sometimes that happens. If it's a really good tool and it's been done like that before, sometimes you can borrow other people's findings. You're better off if you replicate those things. But what we've found is that our students that spend a lot of time validating instruments and validating techniques and range of motion measurements tend not to move very far beyond that. So some sort of compromise within that, especially when you're first starting out. The most important thing, one of my friends from West Virginia who's in sport and exercise psychology, his name's Dr. Sam Zizzi. I was telling him one time about these 4 studies I had going. And he said, the most important thing about your first study is finishing it. And I thought, oh, that's a good point. And he wasn't even being super critical. He was just like, somebody who's not published anything before. The first couple is getting them done, getting them through that process. And so keeping it simple and meaningful is going to be your key to kind of having a successful start to your career. Okay. thank you. And again, if you enjoy this or have comments, please leave comments below. If you have other questions or other areas, then put that in the comment section. If you like it, then like it and share it if you want. I don't know who shares this kind of thing, but I would. And then subscribe if you feel so inclined, if you want to see when we come out with a new one. All right. Thank you. Take care.